بسم الله الرحمن الرحيم. I am Dr. Ahmed Al-Sabbagh. Today, inshallah, we will start our first lecture in our MRCS Part A course. As usual, we will start with anatomy, and the first chapter in anatomy is upper limb anatomy. Okay? Before starting the lecture, I just want to tell you that during the course, you will study from our study materials that you will find in Telegram group. Okay? You don't have to study all the information mentioned in our study materials because some of them are just for just for reading, okay, to be able to understand what is written. So please, during the lecture, you should highlight in the important information that I will mention. I will tell you what is important for part A and what will be just for reading. Okay. Now we will start our lecture with muscles of pectoral region. Before starting with the muscles of pectoral region, we will ask ourselves three questions. Okay. Please look with me to this picture. It is the upper end of the humerus. Okay. This structure is called greater tuberosity. This one is called lesser tuberosity. Okay. This groove between the greater and the lesser tuberosity is called bicepital groove. This bicepital groove has a lateral lateral lip, medial lip, and the floor. Okay, okay. We have three muscles. We have three muscles attached to the bicepital groove. What are these three muscles? Okay. Additionally, as I told you, this is the greater tuberosity. Okay. We have also three muscles attached to the greater tuberosity. So what are the three muscles attached to the greater tuberosity? This is the second question. Okay. This is the scapula. Okay. Okay. This structure in the scapula is called spine of the scapula. We have a fossa over it, above it, and a fossa below. The fossa above is called supraspinatus fossa or supraspinous fossa. The fossa below is called infraspinatus fossa or infraspinous fossa. Okay, this is the dorsum of the scapula, dorsal surface of the scapula. Okay, this is the ventral surface of the scapula. Find this very large fossa, which is called subscapular fossa. Okay, okay. We have three muscles attached to these fossae. Each fossa, supraspinous, infraspinous, and subscapular fossa, each one has a single muscle. Okay. This process in the scapula, this large one, is called the acromion. And this small one is called coracoid process. This coracoid process also has three muscles. So we have also three muscles attached to coracoid process. So during this lecture, we will collect the answers for these four questions. Okay? Okay. Now let's start the muscles of pectoral region. We will start with pectoralis major muscle. Okay? Okay. This is the pectoralis major muscle. As you can find in the picture, it has two heads, clavicular head and sternocostal head. The clavicular head originates from the anterior surface of medial half of the clavicle. Okay. The second head is called sternocostal head. So sterno and costal. Sterno, it originates from the anterolateral surface of the sternum, and costal, it originates from the upper six costal cartilages. Okay, okay. So this is the origin. What is the insertion? It is inserted into, yes, the bicipital groove. So I told you before that the bicipital groove has three muscles attached to it. One to the lateral lip, one to the groove, and the third one into the medial lip. Pectoralis major is inserted into the lateral lip of the bicipital groove. So now we have a single muscle. Okay. This is its insertion. Okay. Okay. We will collect all of these muscles during the lecture. Okay. Origin and insertion. Okay, let's shift to pectoralis minor, which is, by the way, its origin is only just for reading. Okay, it originates from the outer surface of the third, fourth, and fifth ribs, and it is inserted into coracoid process. So I told you before that we have three muscles attached to coracoid process. This is the first one, pectoralis minor. Okay, okay. Serratus anterior. This is serratus anterior, and it is the most important one. It originates, as you can see, by 8 digitations. Yes, these are called digitations. By 8 digitations from the outer surface of the upper 8 ribs. Okay, this is its origin. By 8 digitations from the outer surface of the upper 8 ribs. Its insertion, it is inserted into, as you can see in the picture, into the medial border of the scapula. Medial border of the scapula, especially in the ventral aspect of the medial border of the scapula. Okay? Okay, its insertion, just know that it is attached to the medial border of the scapula. Okay? Okay. This is about the origin and insertion. Okay, nerve supply. Pectoralis major muscle, it is a major muscle. So it has two nerves, which are medial and lateral pectoral nerves. Okay. Pectoralis minor muscle, because it is a minor, it has a single nerve supply, which is medial pectoral nerve. Never to forget that it is the medial one. In MCQ, you will get confused between was it medial or lateral? It is medial. It is called minor, starting with M, so it's M, medial pectoral nerve. Okay. Serratus anterior, and this is the most important information in this table, must be asked in the final exam. Serratus anterior nerve supply is long thoracic nerve. Long thoracic nerve or long thoracic nerve of belly. Very important. Okay? Okay. What is the action of pectoralis major? Don't even read it. Not important for part A. What is the action of serratus anterior? It is important. The action of serratus anterior is fixing the scapula to the posterior thoracic wall. Okay. What will happen if the serratus anterior muscle is paralyzed or there is injury to its nerve supply? We will find this picture. The patient will have what is called winging of the scapula. It will be like that. How can we diagnose it? We will ask the patient to push against the wall. So we will find the winging like this. Okay. What is the cause of winging of scapula? Injury to serratus anterior or its long thoracic nerve. Okay. Okay. This is what you should know from this table. Excellent. Clevy pectoral fascia, a simple and easy topic. You only want to know what are the structures piercing the clavipectoral fascia. What is the clavipectoral fascia? Clavipectoral fascia is a fascia under pectoralis major muscle. This is the pectoralis major muscle, okay? It includes the pectoralis minor. This is pectoralis minor muscle, okay? And this green line is the clavipectoral fascia. Okay, this one, it includes pectoralis minor and attach it with the base of axilla. Okay, what are the structures piercing it? These three structures. They are in the mnemonic clav. From its name, it's called clavy, so the structures piercing it are called clav. C for cephalic vein, L for lateral pectoral nerve, A for acromiothoracic artery, and F fat and lymph nodes. Okay? Okay. Muscles of the back. We have two muscles in the back. The first one is called trapezius, this large one. The second one is called latissimus dorsi, this large one. Okay? Okay. Origin of both muscles are only important for part B, not important for part A. Okay? The insertion. Insertion of trapezius is not important. Okay, insertion of latissimus dorsi, it is the muscle that is inserted into the floor of the bicipital groove. So now we have two muscles, two out of the three muscles needed for the attachment in the bicipital groove. We have pectoralis major in the lateral lip. We have latissimus dorsi in the floor. So we have a single remaining muscle that will be inserted into the medial lip. Okay. So this is the insertion of latissimus dorsi. This is latissimus dorsi, and this is its insertion into the floor of bicipital groove. Okay. Nerve supply of both muscles are extremely important. Nerve supply of trapezius is spinal accessory nerve, which is the cranial nerve number 11. Okay. And latissimus dorsi is supplied by nerve 2 latissimus dorsi, or it has another name, which is thoracodorsal nerve. Thoracodorsal nerve. Okay? Okay. Now with the final option in these muscles, which is the action. Before starting demonstrating the action of each one, we want to look at this picture. Okay, this one. This is the shoulder abduction grades. Shoulder abduction is not a single movement. It is a complex movement divided into 3 grades, 1, 2, 3. Each grade is controlled by a single muscle. Okay? Okay. This is the first grade from 0 to 15, which is controlled by a muscle which is called supraspinatus. Supraspinatus. The second grade is controlled by a muscle called deltoid. So from 15 to 90 is controlled by deltoid muscle. Excellent. From 90 to 180 controlled by 2 muscles, which are trapezius and serratus anterior. So shoulder abduction has 3 grades, from 0 to 15 by supraspinatus, from 15 to 90 by deltoid, and from 90 to 180 by coupling action of trapezius and serratus anterior. Okay, so what will be the action of trapezius? The action of trapezius is shoulder abduction from 90 to 180 with the help of serratus anterior. Okay, and these are the grades of shoulder abduction. Very important. Okay, okay. Trapezius has another action. Please add it to the notes, which is shrugging of the shoulder. Shrugging of the shoulder. Okay? Okay. Action of latissimus dorsi is not important. So what you will have to know from this table is the insertion of latissimus dorsi, nerve supply, which is extremely important, and the action of trapezius. Okay? This is the shoulder abduction grades, as I told you. Now, with muscles of shoulder region, we have 6 muscles of shoulder region. Okay, okay. Supraspinatus, infraspinatus, subscapularis. Let's discuss these 3 muscles. Okay, I told you that in the scapula we have supraspinous fossa, infraspinous fossa, and subscapular fossa. And this will be the origin of these 3 muscles. Supraspinatus from supraspinous fossa, infraspinatus from infraspinous fossa, and subscapularis from subscapular fossa. This is the origin of the 3 muscles. Excellent. The insertion. I told you before that the greater tuberosity has 3 muscles attached into it. This question, the second one, 3 muscles attached to the greater tuberosity. The 3 muscles are in this table. They are supraspinatus, infraspinatus, and teres minor. Supraspinatus, infraspinatus, and teres minor. Okay, okay. So what is the insertion of this one, which is subscapularis? Subscapularis takes its origin from a large fossa, which is subscapular fossa. So it will have a separate insertion. This separate insertion is called lesser tuberosity of the humerus. Lesser tuberosity of the humerus. Never to forget it. Must be asked in every exam. What is the insertion of subscapularis? It is inserted into the lesser tuberosity of the humerus. Okay? Okay. The other muscles inserted into greater tuberosity are supraspinatus, infraspinatus, and teres minor. So now we have cleared this question. This question now is cleared. The three muscles are supraspinatus, infraspinatus, and teres minor. Okay, what is the muscle inserted here? Also cleared. Subscapularis. Excellent. Excellent. Okay. Nerve supply. Just know the nerve supply of supra and infraspinatus, which is the suprascapular nerve. Both muscles are supplied by suprascapular nerve. Nerve supply, action, just know the action of supraspinatus, which I have already mentioned, which is shoulder abduction from 0 to 15. Okay? Okay. Subscapularis, nerve supply is not that important. Just know it, upper and lower subscapular nerve. Action is not important. Now with teres minor and teres major. Teres minor originates from the upper two-thirds of the lateral border of the scapula. Okay? Upper two-thirds of lateral border of the scapula. Teres major from the lower one-third of lateral border of the scapula. Just know that. Okay? Okay, its insertion, yes, it is into the medial lip of bicipital groove. So now we have cleared this question too. What are the three muscles attached to bicipital groove? Lateral lip, pectoralis major. Medial lip, teres major. And in the floor, latissimus dorsi. So we have two major muscles in the lips. Lateral lip pectoralis major, medial lip teres major, and in the floor we have the latissimus dorsi. So now we have cleared two questions. Excellent. Okay, teres major nerve supply and action is not important. Now to the deltoid muscle, which is very important. What is the most important information I must know about the deltoid muscle, Dr. Ahmed? Nerve supply, which is by axillary nerve, and the action, which is shoulder abduction from 15 to 90. Just know this action, the action of middle fibers. Okay? So nerve supply is by axillary nerve. We have two muscles. Sorry. We have only two muscles supplied by axillary nerve, and the two muscles are extremely important for the final exam. Deltoid is the first one. What is the second one, Dr. Ahmed? Teres minor. Deltoid and teres minor. This information with the insertion of subscapularis are the most important two informations in this table. Okay? Okay. Axillary nerve supplies two muscles, deltoid and teres minor, frequently asked in the final exam. Okay, so again, supraspinatus, infraspinatus, and subscapularis. Origin from the fossae. Insertion, supraspinatus, infraspinatus, teres minor into GT, greater tuberosity. Subscapularis into LT, lesser tuberosity. Excellent. What about the nerve supply? Supraspinatus and infraspinatus are supplied by suprascapular nerve. The action of supraspinatus is shoulder abduction from 0 to 15, as I told you before. Okay. Teres minor and deltoid are supplied by axillary nerve. Axillary nerve. Okay. The action of deltoid is shoulder abduction from 15 to 90. Just know this from this table. Okay. Okay. Rotator cuff muscles. They are four muscles: supraspinatus, infraspinatus, teres minor, and subscapularis. In a brief, they are the muscles attached to greater tuberosity and lesser tuberosity. In a brief, in order not to forget them. What are the muscles attached to GT, greater tuberosity? The three muscles: supraspinatus, infraspinatus, teres minor. What is the single muscle attached to LT, lesser tuberosity, is subscapularis. Okay? Okay. What is the importance of these four muscles? The importance is supporting of the shoulder joint, because shoulder joint is a weak joint, because the gluteal the glenoid cavity is shallow, not deep. It is shallow. So the shoulder joint must be supported by other factors like ligaments and muscles. The muscles supporting are called rotator cuff muscles. The shoulder joint is supported from above by supraspinatus, from anterior part by subscapularis, from behind by infraspinatus anterior minor, and it is not supported from below. So it is a common site of dislocation. Just know this about rotator cuff muscles, okay? The intermuscular spaces. What are the intermuscular spaces? This is the humerus, okay? This is the scapula. This is the teres minor muscle, and this is the teres major muscle, and this is the long head of a muscle called the triceps. Okay, okay. The interaction between these structures will form three spaces. This one is called quadrangular space. This one is called upper triangular space. And this one is called lower triangular space. Okay, let's talk about the boundaries. I will tell them for a single try, because they are just for reading. Okay, this quadrangular space from the picture: superiorly teres minor, laterally humerus, medially long head of triceps, inferiorly teres major. I think very easy. Upper triangular, superiorly teres minor, inferiorly teres major, laterally long head of triceps. Excellent. The lower triangular, superiorly teres major, laterally humerus, medially triceps. Okay, these boundaries are important for part B, not for part A. So just for reading. What are the structures inside or the contents of these spaces? This is important. Okay, okay. Structures inside the quadrangular space. They are, as long as the space is near the bone, which is the humerus, it will contain a very important nerve. The quadrangular one will contain the axillary nerve. The lower triangular space will contain the radial nerve. Okay, okay. The axillary nerve is accompanied by posterior circumflex humeral vessels, and the lower triangular space is accompanied by profunda brachii vessels. The upper triangular space contained the circumflex scapular vessels. Okay, okay. You must know the contents. Contents are important. How to remember the boundaries without effort? By looking to this picture. Make your fingers like this. Okay, try to make it. This is the humerus. This is the teres minor, teres major, triceps. And these are the spaces. You will never forget them by this way. Okay? Now to the axilla. What is important in axilla, Dr. Ahmed? The important in axilla are the contents of the axilla. And I will highlight in specific contents in the contents. Okay. The first important structure is called the intercostobrachial nerve. Intercostobrachial nerve. This is the intercostobrachial nerve. Very important. Okay. What is the intercostobrachial nerve? Intercostobrachial nerve is a branch from the second intercostal artery. Sorry. Branch from the second intercostal nerve. Branch from the second intercostal nerve. It extends from the second intercostal space to the base of the axilla. Okay. So what is the nerve supply of the axilla? Sensory nerve supply of the axilla. It is the intercostobrachial nerve. Intercostobrachial nerve. This is very important. Nerve supply of the axilla is the intercostobrachial nerve. What is the origin of the intercostobrachial nerve? It is a branch from, or it is a continuation of the second intercostal nerve. Second intercostal nerve. Okay. This is the first information that you have to know. What is the second one? Imagine with me this scenario. A female that is diagnosed recently with breast cancer. And this cancer has spread to the axillary lymph nodes. So the treatment of this patient will be mastectomy, removing the breast or removing the tumor, however the management will be, and removing the axillary lymph nodes by an operation which is called axillary lymph node dissection. Okay. During the axillary lymph node dissection, during this operation, what are the most important or what are the commonest nerves to be injured? These are these two nerves. This one and this one. Long thoracic nerve, this one, and thoracodorsal nerve, this one. They are the nerve supply of Serratus Anterior and Latissimus dorsi. So, during axillary lymph node clearance or axillary lymph node dissection, what are the most important injured nerves? They are long thoracic nerve and thoracodorsal nerve. Okay, these are the information that you have to know from the contents of the axilla. Just know this, and the rest is just for reading. Okay, okay. Now we will talk about the brachial plexus. Brachial plexus is a very, very important topic for the final exam. Before starting talking about the brachial plexus, I want you to look with me to this picture. Okay. This picture demonstrates the spinal nerve and how it is formed. This is the spinal nerve. This short part is called the spinal nerve. What is the origin of the spinal nerve and what is the fate of the spinal nerve? The origin is from these two roots, ventral root and dorsal root from the spinal cord. So the spinal cord gives a ventral motor root and a dorsal sensory root. The fusion of these two roots will form the spinal nerve, and then the spinal nerve will give dorsal ramus and ventral ramus. Okay? Okay. So, the brachial plexus is formed from this ventral rami. Of which spinal nerves? It is formed from the ventral rami of C5, C6, C7, C8, and T1. So the brachial plexus is formed from the ventral rami of C5 to T1. Okay. The brachial plexus is formed from 5 main stems. The first one is called roots. And what are the roots? These are the roots, which are C5, 6, 7, 8, and T1. The second part of the brachial plexus is called trunks. Okay, what are the trunks? Trunks are C5 and C6 will unite together, forming the upper trunk. C8 and T1 will unite together, forming the lower trunk. And the C7 alone will form the middle trunk. So we have upper trunk formed by C5 and 6, lower trunk formed by C8 and T1, and middle trunk, which is formed by C7 alone. Excellent. Okay. After we will have what is called divisions. What are the divisions? Each trunk will divide into anterior and posterior divisions, like this: anterior and posterior, anterior and posterior. Okay. After that, we will have chords. What are the chords? The posterior division of each trunk will unite together, forming what is called posterior chord. Excellent. The anterior divisions, of the upper and the middle trunks will unite together to form the lateral chord. Okay. So now we have a single division, which is the anterior division of the lower trunk, which will form along the medial chord. So now this is the brachial plexus. So we have roots, trunks, divisions, and chords. The roots are from C5 to T1. Ventral rami of C5 to T1. Excellent. C5, 6 unit together to form the second part, which is the upper trunk. C8 and T1, lower trunk. C7 alone, the middle trunk. Then Each trunk will divide into anterior and posterior divisions. The posterior division of each trunk will unite together to form the posterior cord. The anterior division of both upper and the middle trunks will form the lateral cord, and the anterior division of the lower trunk alone will form the medial cord. Okay? Okay, what is the last part of the brachial plexus? It is the branches. Branches of each cord. Each of these cords will give very important branches. So what are these branches? Let's see together. So this is the brachial plexus, roots, trunks, divisions, cords, as I told you. Okay, the branches. Each cord will give specific branches. Okay, let's start with the branches of the posterior cord. Branches of the posterior cord are in the mnemonic ulnar. U, upper subscapular nerve. L, lower subscapular nerve. N, nerve to latissimus dorsi or thoracodorsal nerve. Axillary nerve and radial nerve. These are the branches of the posterior cord in the mnemonic ulnar. But please take care, the ulnar nerve is not from these branches. Okay, the mnemonic is only the ulnar, but ulnar nerve is a branch from the medial cord. This is the ulnar nerve. Okay, never to forget this. Okay. What are the branches of lateral cord and what are the branches of medial cord? Excellent. Lateral cord gives lateral pectoral nerve. So the medial cord will give the medial one, medial pectoral nerve. Excellent. Median nerve, we have a very important nerve in the upper limb, which is called the median nerve. Median nerve has two roots, has lateral root and the medial root, and the two roots will form the median nerve. So the lateral root of median nerve is a branch from the lateral cord. The medial root of the median nerve is a branch from the medial cord. Okay? Okay. Then each one will give a very important nerve. Lateral cord gives a branch which is called musculocutaneous nerve, which is the nerve of the anterior compartment of the arm. Excellent. The medial cord will give the ulnar nerve, which is a very important upper limb nerve. Okay. Medial cord also gives the medial cutaneous nerve of arm and the medial cutaneous nerve of forearm, but they are not that important. Okay. Just know these three and these three. Okay. Okay. These are the branches of the cords. Okay. So during studying musculocutaneous and the ulnar nerves and the median nerve, we don't have to know the origin because, of course, musculocutaneous nerve is from the lateral cord. Ulnar nerve from the medial cord. Median nerve, it has a lateral root and a medial root. Lateral root from lateral cord, medial root from medial cord. Okay, additionally, axillary and radial nerve, we will also study them. Axillary nerve from the posterior cord of the brachial plexus. Radial nerve also from the posterior cord of the brachial plexus. Okay? Okay. Now with the injury of the brachial plexus, we have two common sites of injury of the brachial plexus. The injury may happen here in this site. So it may happen in the upper trunk and may happen in this site, which is to the lower trunk. Okay. The upper trunk, which is formed by C5 and C6, supplies the proximal part of the upper limb. What is the proximal part? The shoulder and the elbow. Shoulder and elbow. Okay. The lower trunk, which is formed by C8 and T1, supplies the distal part of the upper limb, which is the hand. Okay. The injury to the upper trunk will cause what is called herpes palsy. So herpes palsy is a proximal injury. Lower trunk injury will cause what is called clumbex paralysis. So clumbex paralysis is considered a distal injury. Okay. In every type of these injuries, we will have to know what is the site of injury, what is the motor problem, what is the sensory problem, and what is the deformity. Okay, excellent. What is the site? Of course, all of us know it. The site of each lesion, herpes palsy in upper trunk of the brachial plexus, C5 and C6. Clumbex paralysis, of course, it is in the lower trunk, C8 and T1. Excellent. Okay. What is the motor lesion? Okay. Just remember that I told you that in case of herpes palsy, it affects the proximal part, which is shoulder and elbow. And in clumbex paralysis, it affects the distal part, which is the hand. Okay. What is the herpes palsy? Just look with me to this picture. This describe the shoulder and describe the elbow. The shoulder is adducted or abducted. It's of course adducted. Okay. Internally rotated or externally rotated. The hand is looking backward. So it's of course internally rotated. Okay, the elbow is flexed or extended? It's extended. Okay, supinated or pronated? Yes, the hand looks backward, so it is pronated. Okay, this is the herpes palsy. So the shoulder is adducted and internally rotated. The elbow is extended and pronated. Why? Not important for part A. Just know the description of the lesion. Okay, this is about the herpes palsy. Okay, what about the clumbex paralysis? In clumbex paralysis, as I told you before, the injured muscles will be the distal muscles, which are the muscles of the hand. especially the intrinsic muscles of the hand, which are lumbricals and interossei. So, what is the action of lumbricals and interossei? The main action is this movement here, which is flexion of the metacarpopharyngeal joint and extension of the interphalangeal joint. Okay. In case of clumbex paralysis, this action will be eliminated. So the reverse will happen. What is the reverse? There will be extension in this joint. Yes, this one, which is the metacarpopharyngeal joint, and flexion in this joint. Yes, this one, which is the interphalangeal joint. So we will face this deformity, which is called claw hand. Okay, this is the brachial plexus from the very base. Okay, okay. So in case of herpes palsy, what will be the motor problem? There will be, we will describe the shoulder as adducted and internally rotated. We will describe the elbow as extended and pronated. Okay. In clumbex paralysis, what will be the problem? Paralysis in muscles of the hand there will be hyperextension in the metacarpopharyngeal joint and flexion in the interphalangeal joint. Okay? Okay. What will be the deformity? In herpes palsy, describe the policeman. Remember the policeman. The deformity is called policeman tip paralysis, policeman tip deformity, or policeman tip paralysis. In clumbex paralysis, the deformity is called claw hand. Excellent. What about the sensory problem? Look with me to this picture, please. Yes. What is this picture, Dr. Ahmed? This picture is called the dermatomes of the upper limb. The dermatomes of the upper limb. What are the dermatomes? Dermatomes means what are the parts in the body supplied by specific spinal nerves. Okay, okay. This part is supplied by C5. This part is supplied by C6. Okay, and etc. Okay. So in case of upper trunk lesion, what is the upper trunk? Yes, of course, it is C5. So in case of herpes palsy, we will lose the sensation from the area supplied by C5 and the C6, which are these areas, C5 and C6. Okay, in case of clumbex paralysis, we will lose sensation from the sites supplied by C8 and T1. This is C8 and this is T1. So what will happen in case of herpes palsy? There will be loss of sensation on the lateral surface or lateral part of arm and forearm. what will happen in clumbex paralysis or in case of injury to the lower trunk of the brachial plexus, there will be loss of sensation over the medial part of forearm and hand. Okay, it's very obvious from the picture. Okay, okay, so this is the injury to the brachial plexus. The cause: injury to upper trunk, injury to lower trunk. Motor: the shoulder is adducted, internally rotated. Just know this. Elbow is extended and pronated. Okay. Here in the clumbex paralysis, there will be paralysis of all intrinsic muscles of the hand, hyperextension of metacarpophalangeal joint with flexion of the interphalangeal joints. Sensory: loss of sensation over radial side or lateral side of arm and forearm. Here there will be loss of sensation over ulnar surface of of forearm and hand. The deformity will be policeman tip paralysis or waiter's tip deformity. Here in clumbex paralysis, it will be complete claw hand. Okay, this is the shape of Erb's palsy, and this is the shape of complete claw hand. Okay. This is the shape of the brachial plexus. Okay. Cutaneous nerve supply of the upper limb. Okay. We will divide it into areas. The first area will be the lateral surface or the lateral part of arm and forearm. Lateral part of arm and forearm are supplied by the arm nerves. What is the arm? A, axillary nerve. R, radial nerve. M, musculocutaneous nerve. So this part, which is the upper lateral part of arm, is supplied by axillary nerve. The lower lateral part of arm is supplied by radial nerve. The lateral part of forearm is supplied by musculocutaneous nerve. This is the sensory supply of the upper limb. So arm, A, R, M. Okay, never to forget it. I think it's easy now. The lateral part of arm and forearm are supplied by the arm mnemonic. A, upper lateral part of arm supplied by A, axillary. Lower lateral part supplied by R, radial. Lateral part of forearm is supplied by M, which is the musculocutaneous nerve. Excellent. This is the first part. What is the second question? What is the nerve supply, or what is the cutaneous nerve supply of the posterior part of arm and forearm? Posterior part of arm and forearm are supplied by radial nerve. So the radial nerve supplies these blue parts: lower lateral part of arm and posterior part of arm and forearm. Okay, okay. This is the second question. What is the third question? What is the nerve supply of the hand? Which is very important. What is the nerve supply of the hand? Okay. Median nerve, sorry. First of all, the hand is supplied by three main nerves. They are median, radial, and ulnar. Okay. This is the ventral part of the hand, or the palm of the hand, and this is the dorsum of the hand. So this is the palm, and this is the dorsum. Excellent. Okay. This is the median nerve, and its color is red, as you can see, and it supplies the red colored areas in this picture. So this is the palm of the hand. So describe from the picture. Red median nerve supply the lateral 2/3 of the palm of the hand and the lateral 3.5 fingers on the palmar surface of the hand. This is the median nerve. Okay. The radial nerve supplies the lateral 2/3 of dorsum of hand and lateral 3.5 fingers on dorsum of hand. Okay, so this is an area and the fingers are another area. So median supplies medial 2/3 of palm of hand and medial 3.5 fingers on palmar surface of hand. Okay, on the other side, this is an area and the fingers are a separate area. Radial nerve supplies the medial 2/3 of dorsum of hand and the medial 3.5 fingers on the dorsum of the hand. Excellent. Okay. The ulnar nerve, which is the blue part, supplies the blue colored areas, which are which are medial 1/3 of palm of hand and the medial 1/3 of dorsum of hand. Medial fingers on palmar surface of hand and the medial 1.5 fingers on dorsum of hand. This is the nerve supply of ulnar nerve. Okay, a single trick. Radial nerve supplies the lateral 3.5 fingers on dorsum of hand except the tips of fingers. Except the tips of finger, which is supplied by the median nerve. And this is a site of question. The examiner will tell you that a man during smoking a cigarette, the cigarette burned the tips of his fingers. So what will be the carrying nerve of this sensation? It will be median, not radial. Median, not radial. Okay? Okay. Now with the axillary nerve. Nothing new. Not a single information. Axillary nerve origin. Of course, from the posterior cord of the brachial plexus. Okay. What is the course? Its course is in two areas. The first area in the quadrangular space, as I told you before, with the posterior from flexohumeral artery. The second area is that it winds around the surgical neck of the humerus. Okay, okay. What are the branches? Articular, not important. Muscular to deltoid and teres minor, which is very, very important. Sensory or cutaneous to skin over upper half of the lateral side of arm. Yes, this one, axillary nerve, supplies the upper lateral side of arm. So nothing new till now. Okay. In case of injury, which is due to fracture of surgical neck of the humerus, axillary nerve winds around the surgical neck of the humerus. Sensory loss over the upper lateral side of arm. Motor effect paralysis of deltoid and teres minor. Okay. So there will be loss of shoulder abduction from 15 to 90. Okay. What will be the deformity? Deltoid make a contour of the shoulder. Deltoid muscle makes the contour of the shoulder. So in case of paralysis of axillary nerve, there will be atrophy of deltoid and there will be a deformity called flat shoulder. Flat shoulder. Okay? Okay. Now to the axillary artery. This is the aortic arch. Okay, it gives three branches: brachiocephalic, left common carotid, left subclavian. The brachiocephalic artery will divide into right common carotid and right subclavian. Okay. The right subclavian artery, this blue part, will end at the outer border of the first rib to be completed as the axillary artery. Okay. The axillary artery will continue in this yellow color until it reaches the lower border of teres major, where it continues as the brachial artery. So this is the tree of the axillary artery. Okay, so where is the beginning? At the outer border of the first rib. Where is the end? At the lower border of teres major. Okay. This axillary artery is crossed by the pectoralis minor muscle, which will divide it into three parts. The first part is before the muscle. The second part is behind the muscle. And the third part is below the muscle. So the origin, it begins at the outer border of first rib as a continuation of the subclavian artery. Termination at the lower border of teres major by becoming the brachial artery. The course, it is crossed by pectoralis minor to be divided into three parts. First part above the muscle, second part behind the muscle, and the third part below the muscle. Okay. The first part gives a single branch, which is called superior thoracic artery. The second part gives two branches, which are called acromiothoracic and the lateral thoracic arteries. The third part gives three branches, which are called anterior and the posterior circumflex humeral arteries and subscapular artery. Okay, these are the branches of the axillary artery just for enumeration. Okay. Now with the muscles of arm. Muscles of arm. Okay. The arm, this is the arm. It has two muscle groups. Anterior group, this is the anterior group, and this is the posterior group. Okay. These three muscles are called the anterior group. And this single muscle is the posterior group. So, the anterior group is formed of three muscles: coracobrachialis, brachialis, and biceps. Coracobrachialis originates from the tip of coracoid process. And this is the second muscle that originates from the coracoid process. The first one was the pectoralis minor that takes an insertion from the coracoid process. Okay. The insertion is not important. Brachialis originates from the front of the lower half of the humerus. Not important. It is inserted into the ulnar tuberosity of the ulna. Ulnar tuberosity that is present over the coronoid process of the ulna. Okay. Biceps. Biceps has two heads. That's why it's called biceps. It has a short head and a long head. The short head originates from the tip of coracoid process with the coracobrachialis. And this is the third muscle which which is attached to coracoid process. So now about the question of we have three muscles attached to coracoid process. Now it is complete too. What are these three muscles? They are pectoralis minor, coracobrachialis, and biceps. Short head of biceps. Okay. The long head of biceps originates from the supraglenoid tubercle. The scapula okay, the scapula has this part which is called glenoid fossa, has a tubercle here which is called the supraglenoid tubercle, and another tubercle here which is called infraglenoid tubercle. Okay, so the long head of biceps originates from the supraglenoid tubercle. Okay, okay. The insertion of biceps into radial tuberosity. So the brachialis is inserted to ulnar tuberosity, and the biceps is inserted into radial tuberosity, and this is important. Okay, okay. What is the nerve supply of the anterior group? All the anterior group is supplied by a single nerve, which is musculocutaneous nerve. Musculocutaneous nerve, except the lateral part of brachialis, which is supplied by radial nerve. So, in order not to forget it, the medial part is supplied by musculocutaneous nerve. Never to forget that. Okay? Okay. The action, just know the action of biceps, which is flexion of the elbow and the supination. It causes supination. We have two muscles causing supination of the forearm, biceps and the supinator. Okay, okay. Now with the posterior compartment, which is a single muscle, which is triceps. Triceps has three heads. Okay. The origin, it has three heads: long head, lateral head, and the medial head. The long head of biceps originated from supraglenoid tubercle. The long head of triceps originates from the infraglenoid tubercle. Okay, okay. Lateral head and the medial head. Lateral head and the medial head. This is the back of the humerus, like this. Origin of muscles, origin of the heads of triceps will be in this order: L, L, M. L, long head from the infraglenoid tubercle. L, lateral head from the upper part of posterior surface of the humerus. M, medial head from the lower part of posterior surface of the humerus. Okay, so the lateral head from the back of the humerus above the spiral groove. The spiral groove is a structure that is present here in this site. So you can say above the spiral groove, or you can say the upper part of the posterior surface of the humerus. Okay, so lateral head from the posterior surface of the humerus above the spiral groove, medial head from the posterior surface of the humerus below the spiral groove. The spiral groove is here. This is the spiral groove, which is a site of the radial nerve, as we will know in the next lecture. Here we have the lateral head, and here we have the medial head. Okay. Okay. What is the nerve supply of triceps? Triceps is supplied by the radial nerve. Very, 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 very important. Nerve supply of triceps is radial nerve, and it is the main extensor of the elbow joint. So the posterior compartment causes extension, and the anterior compartment causes flexion of the elbow. Okay. Okay, so this table is very important, and just know what I have highlighted. Okay. Now with the last topic in today's lecture, which is the cubital fossa. Cubital fossa boundaries and contents are very important. Okay, what are the boundaries? What is the cubital fossa? Cubital fossa is the fossa in the front of the forearm, in the front of the elbow joint. The fossa in the front of the elbow joint. So, what are the boundaries? Laterally, this muscle, which is called brachioradialis. Medially, this muscle, which is called pronator teres. The floor is formed by the muscle, which is called brachialis muscle. Just know what is lateral and what is medial. Okay? Okay. The contents, which are the most important point. From medial to lateral, they are in the mnemonic MAPTER. And the order of these structures must be asked in the final exam. Okay, from medial to lateral. M, median nerve. B, brachial artery. T, the tendon of biceps. R, radial nerve. So from medial to lateral, MAPTER. M, median nerve. Then the brachial artery. Then this one, the biceps tendon. And last one is the radial nerve. In the final exam, he will, for example, gives you the biceps tendon and will ask you what is the lateral structure, what is the medial structure to biceps tendon, or gives you the brachial artery, what is medial and what is lateral, and so on. The order of these structures is very important. Okay. Okay. So this is another photo for the cubital fossa. This is the median nerve, then the brachial median nerve, yes, here, brachial artery, then the tendon, biceps tendon, then lastly we have the radial nerve. Okay, so from the next lecture, inshallah, we will start with the 4R. Okay, thank you very much, and see you tomorrow, inshallah.